In this episode of Beyond the Diagnosis, I want to start with a question that might make you slightly uncomfortable. What happens when your patient's watch knows something about their heart rhythm before you do? Pause for a moment and think about that. Not in theory. Not 5 years from now. Today. A patient walks into clinic. They are calm. They feel mostly fine. But their wearable device has been tracking subtle rhythm irregularities for 3 days. An algorithm flags a pattern that suggests early atrial fibrillation. You confirm it. Treatment begins before a stroke ever has the chance to occur. That is not futuristic medicine. That is current medicine. And the real question is not whether artificial intelligence and digital health are coming into our exam rooms. They are already here. The real question is whether we are leading the transformation or reacting to it. As physicians, we are trained to rely on history, examination, clinical reasoning, and experience. Now we are being asked to interpret streams of continuous physiologic data, predictive risk scores, and algorithmic alerts. Some of us feel energized by it. Others feel cautious. Many feel both at the same time. I understand that tension. Artificial intelligence in medicine promises earlier detection, sharper diagnostic accuracy, and more personalized care. Telemedicine expands access. Wearable technology generates continuous insight instead of episodic snapshots. Predictive analytics shifts care from reactive to anticipatory. But let us be honest. With every promise comes responsibility. Recent regulatory discussions have emphasized that innovation must not outpace patient safety. That is not a warning against progress. It is a reminder of our role. We are not technology adopters. We are patient advocates first. So what does this moment actually demand from us as physicians? It demands literacy. Not blind adoption. Not reflexive rejection. Literacy. We need to understand how algorithms are trained. We need to ask what populations were included in validation studies. We need to know the false positive and false negative rates. We need to examine where bias may hide. If we do not ask those questions, someone else will answer them for us, and that someone may not share our clinical priorities. Let me share something personal. I have seen artificial intelligence tools generate alerts that were clinically helpful. I have also seen systems overwhelm clinicians with noise. When every fluctuation becomes a notification, cognitive fatigue follows. More data does not always mean better care. It can mean more distraction unless carefully curated. This is where leadership matters. Digital health integration cannot be a technology project alone. It must be a clinical strategy. That means defining use cases clearly. It means starting with high-impact areas such as chronic disease monitoring, cardiac rhythm surveillance, and post-discharge follow-up. It means piloting programs before scaling them across entire systems. And it means protecting clinical judgment. Artificial intelligence should augment reasoning, not replace it. The final decision must always sit with a human who understands context, nuance, and lived experience. Algorithms do not sit at the bedside during difficult conversations. We do. There is also a legal dimension that we cannot ignore. When predictive systems generate risk scores, documentation becomes critical. If a system flags elevated stroke risk and no action is taken, how will that be interpreted? If an algorithm produces an incorrect alert and we intervene unnecessarily, what is our liability? Healthcare law is still evolving alongside digital tools. That uncertainty requires proactive governance. Institutions must establish oversight committees that include clinical leadership, legal advisors, ethics experts, and information technology specialists. Physicians must have a voice in those conversations. Silence creates risk. Then there is the ethical layer. Who owns wearable data? Who consents to continuous monitoring? Are we widening disparities if only certain populations can access advanced digital tools? Are we medicalizing normal biological variability because we now have the ability to measure everything? These are not philosophical questions. They shape real patient outcomes. I often hear colleagues say, artificial intelligence will replace doctors. I do not believe that. I believe artificial intelligence will replace doctors who refuse to understand it. That is a very different statement. The opportunity before us is extraordinary. Predictive analytics can identify patterns of deterioration before symptoms escalate. Telemedicine can extend specialist access into rural communities. Wearable technology can transform chronic disease management from sporadic visits into continuous partnership. But technology alone does not improve care. Implementation does. So let us make this practical. If you are in private practice, start by evaluating whether your electronic health record system can integrate patient-generated data securely. If you are in a hospital system, advocate for pilot programs with defined outcome metrics. If you are an educator, incorporate digital literacy into residency training. If you are a policymaker, push for clarity around device classification and transparency standards. Small, strategic steps compound. As physicians, we cannot afford to stand at the edge of this transformation and wait. Our patients are already living inside it. They are bringing data into our offices. They are asking questions about algorithmic reports. They are reading about predictive tools in the news. They expect us to know what it means. So here is my challenge to you. Are we prepared to move from episodic medicine to continuous intelligence? Are we ready to interpret predictive risk rather than only diagnose present illness? Are we willing to lead ethically rather than follow commercially? This is not about hype. It is about stewardship. In the coming years, digital health will not be a separate category. It will simply be healthcare. The clinicians who understand that shift early will shape protocols, influence policy, and protect patient safety. Those who do not may find themselves navigating systems designed without their input. We have an opportunity right now to define how artificial intelligence integrates into real clinical life. We can insist on transparency. We can demand validation. We can protect equity. And we can harness innovation responsibly. Before we close, I want to ask you something directly. What has surprised you most about artificial intelligence or wearable technology in your practice? Has it enhanced your decision-making? Has it created unexpected challenges? I genuinely want to know. Leave a comment and share your experience. Your insight may help another physician navigate this shift more confidently. And if this conversation resonated with you, share this episode with a colleague. Forward it to someone who is skeptical. Send it to someone who is enthusiastic. Let us expand this dialogue beyond our individual clinics. We are not just adapting to the future of medicine. We are shaping it. Thank you for joining me on Beyond the Diagnosis. Until next time, continue questioning, continue learning, and continue leading.